Good afternoon. We are coming to you live from the University of the Philippines, Manila, for the 18th Lourdes Manahan Lectures in Rheumatology. I am Michael T. of the Division of Rheumatology moderating this session. I'd like to thank our sponsor, Pfizer, for participating in this webinar. And to all our participants, thank you for joining us today. If you have any question, you can place them at the Q&A box, and we will address them during the open forum after the lecture. You will receive your certificate of participation to this webinar a week after you submit the evaluation form and post-test. The link will be posted at the Q&A box and at the chat box midway through the webinar. As you have seen in the video, LMLR is an annual event hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. The fourth lecture on this year's LMLR will focus on ankylosing spondylitis. Our renowned speaker for today finished her medical education and obtained her master's degree in health professions education at the University of the Philippines, and she completed her residency and fellowship training at the Philippine General Hospital. Currently, she is the Assistant Associate Dean for Academic Development and Chief of the Medical Education Unit at UP Manila. She is also the valuable training coordinator for the Division of Rheumatology in PGH. Dr. Reyes has a passion for teaching, and she has been awarded here with numerous distinctions, including Dr. Andres Cuyegkeng Professorial Chair in Medicine Grant, the Gawad ng Dekada Honor, and the Dr. Luis Mabilangan Award for Innovation in Medical Education in Philippine Clinical Sciences. She was also a past president of the Philippine Rheumatology Association, and her contribution to the field is truly remarkable. Dr. Reyes is a forerunner in the field of spondyloarthritis and heads this special interest group in the Philippine Rheumatology Association. Her expertise has been acclaimed worldwide, and she, in fact, has been instrumental in the 2018 APLAR eggshell spa treatment recommendations. Aside from this, Dr. Reyes has published numerous papers on lupus, RA, vasculitis, osteoarthritis, and crystal arthropathies, which all contribute to what we all know today. Let us welcome my very distinguished colleague, Dr. Bernadette Heizel Manapat Reyes, to discuss ankylosing spondylitis. Ma'am Heizel?
Good afternoon to everyone. I hope my audio is clear. Can somebody tell me if my slides are properly showing?
Clear and showing.
Okay. Thank you very much, Mike, for that very, very generous introduction. I am very honored to be part of the Golden Jubilee celebration of the Division of Rheumatology. And this afternoon, I'd like to share with you this talk about axial spondyloarthritis. The challenge was that our division chief, Dr. Salido, asked me to talk about axial spondylitis, but not talk about the spine. So let's see how we do it. Okay, just a brief historical narrative. It used to be that life was simple. If you see the acronym AS, you think it's ankylosing spondylitis, and that we think about AS as one disease, the sine qua non of which was the classic bamboo spine, as is seen in the picture. However, over the past decade, there has been a change in the way we look at patients with axial spondyloarthritis, or at what we used to term as ankylosing spondylitis. Increasingly, we began asking ourselves, why is it that we make the diagnosis only when there is already damage? There were lessons to be learned from the experience with rheumatoid arthritis and shifting the classification criteria from RA from simply those having erosions to the joint to actually trying to capture patients much earlier. And this same paradigm applied to axial SPA. So therefore, about a decade ago, the classification widened. So it's no longer just ankylosing spondylitis with the classic syndesmophytes, but inclusion of patients who may not have these radiologic problems yet, but will probably go into this stream later on in the course. And the definition of non-radiographic spondyloarthritis became a bit more popular. But even that, we wanted to push the boundary further, or the rheumatologists in charge of this wanted to push the boundary further and see whether there was still an even earlier opportunity to diagnose patients. And of course, the common manifestation was in fact chronic back pain. But we do know that not all back pain is inflammatory in character. So it became imperative to come up with a criteria for inflammatory back pain to cue us in about which patients we needed to be most mindful of. And these are the characteristics of inflammatory back pain. Pain that happens to a person who's relatively young, meaning less than 40 years old, that is insidious in onset. The next two are very telling manifestations, which is pain at night with improvement about getting up, or improvement of the back pain with exercise. And on the opposite end is that there is no improvement in rest. And if you satisfy 4 out of these 5 parameters, then you can actually appreciate that maybe this is not the usual back pain that patients talk about, but an inflammatory back pain. And with that, the bigger picture for axial SPA was more or less became more developed. So now we see that we start out with patients having inflammatory back pain. And from that initial starting point, you can actually diverge into several courses. You can have spontaneous remission, it goes away in itself, but there is a large proportion of patients who actually go into an axial SPA stream. No? So this is non-radiographic axial SPA. So this is an emerging model in our understanding of the natural history of this disease of axial spondyloarthritis. It provides for us an appreciation of the various stages of journey of the patient with axial SPA. So whereas before we only looked at them in terms of this one, which is ankylosing spondylitis, now we're also looking at them in terms of non-radiographic axial spondyloarthritis, meaning the X-ray might be normal, but the MRI is not. And then we appreciate that there are several areas where they can go to. They can persist as non-radiographic axial SPA. They can continue on to have late complications of ankylosing spondylitis. So it is with this framework that the criteria of ASAS for axial SPA was developed in 2009. So again, this is a classification criteria which applied to patients with chronic back pain of more than 3 months, and this is younger patients. What we look for in these patients is evidence of sacroiliitis on imaging. The bigger divergence is that it's no longer just X-ray findings. We have to look at it earlier, and blessedly, we have new technology like the MRI to help us with this, or a positive HLA-B27 feature, and then finding, and then we look at the patient holistically and find out if there are other SPA features that this patient have. And then therefore we can make an earlier and wider classification of these AxSPA patients. The other thing that paradigm brought us is that it allowed for us to appreciate the spectrum of axial SPA, that it is not limited to AS alone or even non-radiographic axial SPA alone. There was an increasing realization that there will be conditions like a psoriatic arthritis, reactive arthritis, or arthritis of IBD that can also have axial symptoms. With this expanded understanding, we hope to recover what is termed the lost tribe of patients with axial SPA. Well, they get lost because of various factors. Number one is there's gaps in the identification of the subset of patients with IBP among the many, many patients we have with chronic back pain. Also, they're lost because there's poor recognition among healthcare professionals of the features of axial SPA or how they relate with extraarticular manifestations. So for instance, if a patient comes in with recurrent red eye, we don't really think of it perhaps as uveitis, and we don't ask the patient about concomitant low back pain. Also, the gap is because there is some cognitive dissonance. We have biases in terms of our understanding of this disease, that we always think of it that the HLA-B27 should be positive, which we now know is not really the case, and that this is a disease mostly of men. So if it's a female coming in with widespread pain, even if the inflammatory markers are elevated and there's widespread pain and chronic low back pain, sometimes the diagnosis gets missed. But what does the data tell us? The data does tell us that over time, we're really improving the recognition that AS, established AS, is not just really a male disease. We're coming to terms and to the terms of diagnosis of more women having ankylosing spondylitis. And if we move our paradigm a bit earlier and look at patients with non-radiographic axial SpA, then we see that this male preponderance actually is not anymore there. That in fact, there might be equal male to female patients with non-radiographic axial SpA. So with that, we move on to the objectives of this talk. I hope that our framework is now clear to everybody. The task that was given to me is to discuss the morbidities associated with axial SpA, and secondly, to discuss appropriate approaches to recognize and manage these conditions. Okay. When we talk about comorbidities in axial SpA, we need to understand that some of them are extra-axial manifestations that are still SpA features, and these might be mediated by mechanisms such as infectious mediators, changes in your gut microbiome, and of course, mechanical stress in a patient who is genetically determined. But likewise, we have comorbidities that result from chronic inflammation and sometimes the drugs that we use. And these are also especially telling that there are some patients who might be particularly susceptible to this. So some of the comorbidities I'm going to be talking about are in fact still SpA features, and some will clearly be comorbidities associated with this chronic condition. Okay, let's start first with your extraarticular manifestations. So I am presenting data from this meta-analysis that describes the pooled prevalence of extraarticular manifestations among patients with ankylosing spondylitis and those with non-radiographic axial SpA across various cohorts. So this covers patients with early disease and also those with established disease. If you look closer, you would see that the mean symptom disease duration is at least a year for those patients with non-radiographic axial SpA, but can actually be as long as 17 years for patients with ankylosing spondylitis. The usual duration the usual gap to diagnosis of patients with this condition is commonly about 8 years. So ang tagal-tagal bago talaga na-diagnose yung mga axial SpA patients natin. And it's even worse if the patient is female. Now, what did they find in this meta-analysis? Number one, it validated the previous observation that the male preponderance in AS is mostly in AS, but that when you're talking about non-radiographic axial SpA, there might not be that pronounced male preponderance. In fact, there might be equal gender distribution. Secondly, HLA-B27 frequency of a positive HLA-B27 is the same or across this stream of non-radiographic axial SpA and AS. But as you see, it's not universal. So 25% of patients, more or less, will probably be HLA-B27 negative. What did they find when they looked for extraarticular manifestations? One is that some manifestations are more common than others. Example, peripheral arthritis and enthesitis can be seen in as much as 35% of our patients. So baka yung mga patients nagko-complain, chronic back pain and heel pain, especially with women, sasabihin natin, baka it's the heels that you wear. Nun pala, inflammatory yung back pain and we're missing out patients with axial SpA. Now, other manifestations, of course, might be less frequent, such as your dactylitis or your sausage digit, or inflammatory bowel disease or psoriasis. But even as they occur, what we see, what this meta-analysis has shown us is that the pooled prevalence is the same for most of these conditions, whether or not you're talking about non-radiographic axial SpA and AS, except for uveitis. So uveitis is a bit more prevalent among patients with AS compared to those with axial SpA. And usually this is an acute anterior uveitis. The bottom line is that we need to actively look for these manifestations for patients with chronic back pain, especially if we have indicators that the chronic back pain is inflammatory in character. Okay, second set of comorbidities would be the usual morbid conditions that the internists in the room encounter, which is cardiac, pulmonary, metabolic problems, and of special interest for axial SpA is osteoporosis. Well, let's cover these one by one. Starting off with cardiac complications of axial SpA. Do you remember when we were students, no? If you're at, it becomes a bit automatic to us. What valvular heart disease will you hear in a patient with ankylosing spondylitis? Aha, aortic regurgitation. And it's the finding that we most commonly associate. But it's not just valvular heart disease that is more common among our patients with axial SpA, but also conduction and rhythm abnormalities and myocardial disease. No? So the pathologies are a bit similar across these different manifestations. No? For conduction and rhythm abnormalities, what we find on necropsy findings is inflammation of the interventricular septum or sometimes anomalies in the AV nodal artery. For valvular heart disease, this happens and it's mostly the aortic valve because the most common finding is endarteritis in the aortic root and the valve. Okay, and that is why aortic regurgitation is the most commonly associated finding. For myocardial disease, it's really a combination of many things. The first is diastolic dysfunction. The second is changes in your microvascular circulation. And third is a complication brought about by metabolic changes. Now, these three particular findings are of concern. Number one, for myocardial disease, our patients have a 2 to 3 times increased risk of infarction compared to age-matched controls. And if we just apply our usual risk assessment scores, such as your Framingham risk score, then we are going to be underestimating the risk for this patient. So we have to be really keen in screening them or asking them about symptoms that might point to heart failure or myocardial involvement. Now, when we examine patients, even if their complaint is back pain, and especially if we've established that this is axial SpA, we really need to listen to the heart because otherwise we might be missing out on the valvular heart disease. And there is a need to establish a baseline ECG and maybe even do follow-up ECG to monitor the presence of AV nodal abnormalities. And one of the things that one interesting paper I read about was monitoring the ECG for QT dispersion. I don't know anymore how to do it, but that's the reason why we should advocate multidisciplinary care in the care of in looking after our patients with axial SpA. The second is pulmonary complications. No? With the advent of HRCT, we're increasingly been able to document HRCT abnormalities in about 40, and this can be seen in as much as 40 to 71% of patients. Common findings in axial SpA will be apical fibrosis. ILD is very common to us. Of course, chest wall restriction, spontaneous pneumothorax, and obstructive sleep apnea. So let's talk about apical fibrosis first. The putative mechanism of this is recurrent aspiration from defective ventilation and the recurrent impaired cough. And apparently, there's also mechanical stress on the apices of the lung from the rigid thoracic spine. In a Taiwanese cohort, they found apical fibrosis in 2.9% of their patients with axial SpA. So maybe that's not very impressive to us. But when they looked at this patients with apical fibrosis, the realization is that the structurally changed lung becomes a good environment for microbial growth, so especially of opportunistic organisms. And in that particular group of patients, they found that 65% of these patients with apical fibrosis had concomitant Mycobacterium tuberculosis. Now, apical fibrosis is really going to be very tricky in our situation wherein we have high prevalence of TB, and it can present unilaterally or bilaterally. The other common finding is interstitial lung disease. No? What they find is that there's chronic inflammatory cell infiltrates in the lung, interstitial fibrosis with elastic degeneration of collagen and hyaline. And interstitial lung disease can be documented in 50% of all patients with axial SpA, and is in as much as a third of patients who may be asymptomatic. Of course, when the patient becomes symptomatic, then it's more likely that you will be able to document interstitial lung disease. Chest wall abnormality is of significant concern because it will bring about restrictive lung disease from the dorsal kyphosis and from the chest wall restriction. As you know, we not only measure flexion of the thoracic spine when thoracolumbar spine actually spinal flexion when we're looking at patients with axial SpA. We also look at their chest wall expansion, and a lot of them have limited chest wall expansion. So if you think about it over the decades, then it's not hard to imagine that this restrictive lung disease can happen. Spontaneous pneumothorax is not very common, but is of concern among patients who have apical fibrosis and smoking. And obstructive sleep apnea can be seen in as much as 12% of patients with axial SpA. And it becomes a bit of a confounder when you have a patient who complains to you of marked fatigue, and you don't know anymore whether the fatigue is because of active disease or is contributed in part by the obstructive sleep apnea. The other comorbid condition of concern that I'd like to bring here is metabolic syndrome. And I'm presenting data from Asian data. So this is two groups of data. One is from Chinese patients with axial SpA. And in that cohort, they had the prevalence of 23% of metabolic syndrome in their group of patients compared to 11% only of patients who do not have AS. So it's twice as much. No? And among AS patients, they had higher BP, higher FBS, even as they had lower lipids. Independent risk factors in their multivariate analysis showed that hyperuricemia and high BMI were risk factors for the presence of metabolic syndrome in this group of patients. And interestingly enough, this is not related to disease duration or disease activity. In the other group of Asian patients with AS, this is a Thai group, the prevalence of metabolic syndrome was about 19%. Likewise, high BMI was a risk factor to them. Age was a risk factor as well. And again, this is not related to disease duration or disease activity, and in their set of patients, not even to smoking. So something else is going on that is mediated probably not just by the common risk factors we associate with metabolic syndromes, and maybe even beyond the simple explanation of chronic inflammation in axial SpA. So as to what is that, we don't know yet. The other comorbid condition of concern is osteoporosis. Now, the prevalence of osteoporosis among our patients with axial SpA, and remember, a lot of them are actually younger males, no? Is 29% in the spine if we measure it by DEXA, and in the hip 12%. This is in comparison to 2 and 1% respectively when you compare them to patients who are not, who do not have axial SpA. And this is very concerning. Clinical vertebral fractures, the odds ratio is 7.7. So ang taas talaga ng clinical vertebral fractures for patients with axial SpA. and the cumulative incidence of clinical vertebral fractures is higher among men and women. But also, again, we do not really think of osteoporosis if you have a male patients. And I've had questions given to me na, pwede palang mag-fracture, akala ko nga stiff yung spine, no? So, having axial SPA actually increases your risk for vertebral fracture and osteoporosis in general. So the practice points we need to remember is that the risk of vertebral fractures is increased in the first 5 years. So it's not only seen among patients with very long-standing disease. We need perhaps to assess the DEXA early in the course of the disease of our patients with axial SPA. So we probably should not wait until they're older. But if we find that there's a lot of risk factors for osteoporosis, perhaps we should consider screening them early. For patients with advanced disease, DEXA is not going to be the best way to do it because all those syndesmophytes are going to mess up our findings. So QCT has a place in the diagnosis. And then because the risk for vertebral fractures is so much higher, we must lower our threshold for spinal imaging if a vertebral fracture is actually suspected. Okay. Now, the third aspect of comorbid conditions that I wanted to address is mental health issues. Now, for this data, I will be describing the results of a meta-analysis that actually included 39 articles with depression and anxiety as outcomes. There were 6 studies in this meta-analysis for which depression and anxiety were primary outcome measures, and in 33, there were secondary outcome measures. The pooled prevalence across the 33 studies describing it as a secondary outcome is as shown in the chart. Now, let's focus on those 6 studies. So 4 of these studies are cohort studies from administrative databases, and you could see that it really covers a large number of patients, no? Mostly with AS, and then 2 studies have cross-sectional data on AS, and one of them actually included non-radiographic axial SPA. So in this group of patients, the age is anywhere from about 30 to 50 years old because the cohorts were described as AS. There was male preponderance in most of them. And these were good studies, no, as you could see from the quality score. What do these studies tell us? Simple, that patients with axial SPA or AS have a greater anxiety and depression. So they're more anxious and more depressed. So whether you're looking at adjusted relative risk or hazards ratio, and these are already adjusted for age, gender, comorbidities, obesity, smoking, income, etc., you would see that our patients with axial SPA have more depression and more anxiety. What was interesting to me is that in this one study that looked at hazard ratio for anxiety, you would see that it's the male patients who are in fact more anxious than the female patients. So this is the incidence estimates for depression among patients with AS. Again, this is from the 4 studies previously presented. So patients with AS have a 51% higher risk of depression compared to patients without AS. That's a very significant number. So these patients are in pain and they're also depressed and anxious because of all that they are going through. Now, what have been the determinants that for depression and anxiety? Well, disease activity as measured by BASDAI or ASDAS-CRP is one. Quality of life. So patients with lower quality of life become more depressed and anxious. This is important, no? Lower educational attainment. In fact, if you look at the odds ratio for educational attainment, mas telling pa siya in terms of depression and anxiety. So if I'm thinking about our patients in PGH, what does this really mean to them? No? So the degree of depression and anxiety or the frequency is probably higher compared to those patients who are more equipped to cope for this condition. Smoking is associated, has an OR of 10 in terms of depression. So we don't know whether they smoke because they're depressed or the smoking is part of the depression. But so cue in all your patients who smoke. Probably we need to check whether part of the reason why they have difficulty quitting is depression. But I'd like to highlight this, the one in pink, that whether or not we're talking about patients with AS or non-radiographic axial SpA, the burden of psychological distress is similar and therefore needs to be addressed. So we go now to the second part of the talk, which is discussing appropriate approaches to recognize and manage the conditions that were previously described. And my task was made simple because I found this model. It was a Spanish model called GCox Model that a group of rheumatologists in Spain developed to help them monitor and screen patients with axial SpA for comorbidities. The GCO is a contraction of Spanish terms that I cannot, I'm not able to say. So, but that's what they call it because they have an RA model as well, and they have a psoriasis model. So this is the axial SpA model. So in terms of monitoring, the model reminds the healthcare professional to ask about lifestyle. So that includes smoking, alcohol use, and physical activity, to ensure that they periodically ask about symptoms that pertain to extraarticular manifestations, such as red eye, blurring of vision, chronic diarrhea, stool changes, or skin lesions. To also ask about the vaccination of patients, because we do know that we need to give some medications and our choice of medications need to be informed as well. And of course, the medication list of patients has to be anticipate comorbidities. The framework also asks us to check blood pressure. This is monthly if the patient is hypertensive, or at least every 2 to 3 months if the patient is not hypertensive. And it has a reminder to do cardiac auscultation for all patients with SpA. Lab-wise, this is what they monitor. So they do a baseline HBV, HIV serology. Here in the Philippines, most of us rheumatologists do check for hepatitis B, but I'm not aware of anyone who periodically checks HIV serology as well. Annual checkup should include markers for your metabolic syndrome, and this can include HbA1c, FBS, your lipid profile. And because nephropathy can happen in axial SpA, also as a consequence of some medications, annual checkup of your GFR, and the recommendation is MDRD, and microalbuminuria using your urine albumin ratio is advocated. Because of the finding of apical fibrosis, and because we know that we need to give drugs that might make them more susceptible to infections, then it's important to do a chest X-ray at baseline and perhaps yearly. And of course, we do an ECG, again, since we see conduction abnormalities among this patient. Now, transaminases should be monitored, especially if there's concomitant treatment with methotrexate or the patient is on a lot of other drugs. Vitamin D is also important to monitor as well because of its impact on the osteoporosis risk assessment. And sleep studies sometimes need to be done if you have a patient complaining of severe fatigue and you can't quite place the fatigue in terms of the activity of the axial SpA. In this in this model, they also check on mental wellness. For depression and anxiety, the scale that is used is your HADS, or your Hospital Anxiety and Depression Scale. For fatigue, it's item 1 of your BASDAI, or the Multidimensional Fatigue Symptom Inventory short form, haba ng name. For sleep, it's Pittsburgh's Sleep Quality Index. And for sexual dysfunctions, there's a tool that is used for men and one for women. So what do their data gathering forms look like? So they look like this. So there is a form for doctors. It's a 3-page form for doctors that ask questions before starting treatment. So they ask about allergies, concomitant medications, evidence for kidney failure. If treatment with NSAID is going to be given or maintained, then risk assessment should be done. And of course, before initiation of any biologic or immunosuppressive therapy, then we assess risk for infection, heart failure, and pulmonary disease as well. Page 2 covers most of the risk factors for comorbid conditions. And this is a reminder for us to actually check this on a periodic basis. The third page for the healthcare professional form is a referral criterion for some extraarticular manifestations. So periodic ophthalmologic consultation for uveitis, monitoring of any GI changes that would indicate the presence of inflammatory bowel disease, or again, cardiac auscultation to check for aortic valve disease, and of course, baseline and annual ECG to check for AV block. And then there is a reminder to ensure that the patient is properly referred should these findings happen. There is a patient form that is much longer. So the patient form is about 5 pages. And this is a self-report of medical history, including their medications, their comorbid conditions. This is a self-report of comorbid conditions, of their vaccination status, okay? And then it gives you biometric parameters, so age, sex, weight. A history of fractures is also asked of patients, and of course, physical activity. There is an equal importance or coverage given for psychological distress. So there's regular monitoring of your depression index using your HADS, sleep quality here, and of sexual function here, and alcohol use. So it's quantitated. And just in case the doctor misses out on extraarticular manifestations, the patient is made to report the presence or absence of a red eye or a painful eye, persistent diarrhea, or cardiopulmonary symptoms. So that is a model for screening that I think some of us might want to try out when we're looking at our patients with axial SpA, so that we will be able to identify problems early. But what do we do when we do see that there are problems? No? So in terms of management, we still start with your non-pharmacologic interventions, and this include maintaining a healthy weight, limiting alcohol intake, avoidance of smoking, very, very important, avoidance of smoking, encouraging our patients to be physically active, and at the same time cautioning them about fracture prevention. So this is basically teaching patients about fall avoidance and cautioning against hyperextension injuries. May mga patients kasi na ganyan they're young men, they're used to playing very active sports, and then even if they have diagnosis already or some stiffness, to them the semblance of normality is still being able to play the sports that they want to play, but sometimes you have to make sure that they are able to manage how this athleticism is balanced with the risk for fractures, especially vertebral fractures. But the bottom line is that we treat comorbidities in axial SpA as we would with patients without axial SpA. I think the biggest divergence in terms of treatment is really in our choice of biologics. So in axial SpA, there are a lot of medications which will be helpful in themselves, including your monoclonal TNF antibodies, etanercept, your IL-17 agents, and even some JAK inhibitors. So even if they're not really licensed for use in axial SpA, but there are studies of some JAK inhibitors having a positive effect in terms of your axial SpA findings. However, when you look at the extraarticular manifestations, then you would see that then you would see the divergence in terms of how all of these available drugs will work. So for uveitis in general, mostly it's your monoclonal TNF inhibitors that are going to have a good result. Etanercept may have good results, but it's not really licensed for use. And there are some drugs which are not going to work for uveitis. For inflammatory bowel disease, then you have some drugs that will work. And look how specific it is. For instance, tofacitinib will work for ulcerative colitis, but not for Crohn's disease. So food for thought. And the other thing to think about is that sometimes there are some drugs which might even be inimical in the presence of these extraarticular manifestations. Psoriasis gives us a bit more leeway because there are a lot of drugs that work on psoriasis, and a lot of them are also effective in terms of the axial manifestation. So the bottom line is that we look at the patient as a whole. We don't just really think about the axial manifestations, but we have to look at the extraarticular manifestations as well, so we could choose our biologic drugs, the most appropriate biologic drugs for them. Okay, and that is my last slide. So in summary, what I wanted to emphasize this afternoon is an evolving view of axial spondyloarthritis. And because we hope that with a better understanding of articular, extraarticular manifestations and imaging findings, will actually facilitate earlier diagnosis of these conditions, and hopefully we will be able to help our patients much earlier before that bamboo spine happens. And to do this, we must be able to overcome our cognitive bias as healthcare workers caring for these patients, that our biases about gender differentiation, about what test results we expect, whether it's imaging or blood tests. We need to be able to expand our understanding of disease so that we will be able to identify a wider group of patients much earlier. And finally, and this ties up with the title of this talk, holistic managements of patients with axial SpA actually necessitate us looking beyond the spine. So thank you very much for this opportunity to share this with you. I'll be glad to answer any questions.
Thank you, Dr. Reyes, for your lecture. I have seen comments coming from our Professor Esther Penserga, saying a lot of learnings. Now, there are some questions here from our audience. Now, what is like this one from an anonymous attendee? What is the most optimal treatment for an axial SpA with renal failure or ESRD?
Ang hirap naman nun. Okay, so again, it's informed really by the whole picture of the patient, no? What your extraarticular manifestations are, is this purely axial, and also in terms of the phase in which the patient is in, no? Iba kasi yung approach if we're talking about a patient with very, very active inflammation versus an end-stage patient already, no, with established syndesmophytes. So that has to be, I do not have a single answer to that because there's so much interplay talaga. So we also have to look at the comorbid conditions of the patient and see what is allowed in terms of medications.
Would you say that biologic agents are safe among patients with ESRD, particularly the monoclonal antibody or this any biologic agent for that matter?
I'm sorry, I'm having problems. I didn't quite hear the last question, Mike.
Do you think that they would be safe for patients with ESRD? Just that subset of drugs or treatment.
I guess we have to approach it on a drug-to-drug basis. No, the unfortunate thing is that if you go by clinical trial data, invariably patients with advanced kidney disease are excluded. No, so I guess it's really going to be a deep dive into the biologic agents of choice that you want to use for that patient.
Thank you. Another question is, in a resource-limited setting, what can be the single most contributory serologic or laboratory test that we can request to diagnose SPA?
Okay. We're actually working towards developing practice guidelines for HL SPA because we do understand that early diagnosis, usually the parameters that all of these criteria suggest, including your HLA-B27 and MRI, can be very costly. So the problem with the ASAS classification criteria is that if you go purely clinical, then sometimes you overestimate, right? But there is an opportunity to actually make a diagnosis. That's a classification criteria, not a diagnostic criteria, without the costly labs. Now, single most contributory or serologic test. To me, if the symptoms are very telling, I do inflammatory markers. No? And there is an interesting paper, however, that for women, no, even sometimes if they have very high inflammatory markers, nai-ignore pa rin yung possibility ng HL SPA. So I guess it's really looking at the symptomatology of the patient and not being shy about labeling it if the symptomatology fits.
There is a comment here, no? Thank you for the excellent lecture. Ma'am, for patients presenting as non-radiologic HL SPA initially, how do we monitor if they have crossed over to AS? Do we do annual MRI to look for sacroiliitis?
Okay. Okay, the good news is that there doesn't seem to be much difference in terms of clinical manifestations and response to treatment, whether it's non-radiographic, HL SPA, or AS. Okay, so knowing whether it has crossed over to AS is mostly an academic concern on our end. Now, how do you check? Well, we say it's AS when it's already, when the findings are already, when the findings are already there on radiograph. So it doesn't require us to repeat the MRI for sacroiliitis. Kasi kung nandoon na yung MRI na sacroiliitis, then non-radiographic HL SPA na. So if you want to monitor whether AS talaga siya or it fits the classification criteria for AS, it's not the MRI that you'll need to repeat, but perhaps an X-ray.
Thank you for that, Dr. Heizel. Another question from Dr. Lenore Lizardo. Thank you for this very informative lecture, Dr. Heizel, regarding tofacitinib on ulcerative colitis. Can this be combined with mesalamine or sulfasalazine if there is not enough control of the articular and extraarticular manifestation?
Len, I have to get back to you on that. No, I honestly did not really do a deep dive into Tofa in ulcerative colitis. So that's my assignment to you. No, but I suppose it can be because perhaps in the clinical trial that, or perhaps in the studies that documented its efficacy in ulcerative colitis, they would not have used Tofa if the response to mesalamine or sulfasalazine are sufficient. I'm just looking at it from a mechanistic standpoint.
Yeah, from a clinical trialist point of view, it's always a failure to...
Failure, yes, exactly.
Failure with the standard of care therapy.
Yeah.
Let's have live question and answer. Let's see. Let me call some of our friends from the division. Dr. Lorenzo is here, sir. Or Dr. Penserga. This is really a division activity, and would like to thank the members of our division of rheumatology for being here and participating to honor our beloved Dr. Lourdes Manahan. Also, our division chief is here. Maybe a question or a comment from our division chief. In the meantime, the question is, what is the best advice for patients who have indications but cannot afford biologics, like most of our Filipino patients?
Yeah, this one we need to address, no? Well, Dr. Lorenzo is the head of APLAR now. And in fact, when we were developing the guidelines for AXPA, no, in APLAR, there was really a huge divide as to how we approach treatment. No, there was a group of physicians in the region who said, but you know that it's just the biologics that's going to work. And then there's the rest of us who were saying, but not all of our patients can afford biologics. So there, in terms of that guideline, there is one statement that says that in resource-limited settings, and I think this is the context of the question, a trial of methotrexate can be done, especially in patients who have peripheral arthritis. That's one. There is some inconsistent data on chronic NSAID use being able to retard some of the axial radiographic manifestations. So there is that as well. But generally, if you're looking at axial SPA, biologics are first choice. But as I said, in a resource-limited setting, we kind of try what we can.
Yeah, and another concern right now is some patients cannot come to the clinic because of our situation. Any advice on how we can improve our ability to diagnose non-radiographic SPA in when we use telemedicine?
Okay. So I think to me it would be careful and keen history taking, really going through that process of differentiating whether the back pain is inflammatory in character, going through that entire checklist of SPA features, family history, any other manifestations. Because, you know, when the patient comes to us, it's back pain, they don't really tell us, oh, and I have this rash here. They don't really tell us, I had this history of red eye. No, we have to really elicit these findings from them. No, so I think for me, the key is careful history taking. We really need to take time with patients.
Yeah, what's good is that maybe in about 3 months, the APLAR will be coming out with a guidance on the use of telemedicine for patients with rheumatologic complaints. So last night there was a second round of live Delphi, and agreements were made. So we can expect proper guidance from APLAR maybe by January next year.
Okay. Oh, that's great to know, Mike.
Comment, Ma'am Heizel, as a leader and an advocate treating and identifying patients with ankylosing spondylitis, can you maybe narrate to us some of your activities so that some of our patients or colleagues who are also interested can join you in this advocacy to identify patients at risk for AS and prevent deterioration of their quality of life?
Yeah. Okay. First of all, before I do that, let me just recognize I'm very glad to see Dr. Pensurga, Dr. Salido, Dr. Lorenzo in the audience. No, all these years of us doing LMLR is really a tribute to the teachers and the rheumatologists who've come before us. No, and I'd like to specially cite. No, we have a student in the meeting, and she's been so keen on rheumatology. Hi, Keisha. And I'm very happy to see that, because this is 50 years of the division of the rheumatology. And when we have young people who want to get engaged, it gives me hope for the next 50 years. Now, I think what's been consistent with PRA, not just our SPASIG, is that we recognize that we cannot hope to care for all of our patients with axial SPA. We need the help of our colleagues, whether it's fellow physicians in primary care, our PTs, super important, no, that we involve them in the care of these patients, because they can help us identify patients early in the disease. No, that's one. So, and the reason why our SIG has been so active, participating in so many things, even patient fora. We have very robust groups for patient support groups for psoriatic arthritis and ankylosing spondylitis, is because we want to make the message known. No, we want to be able, again, the word I use is cognitive bias. No, we have to be able to surmount this among healthcare workers so that mabuksan yung mata. No, kasi that's first step. If we as physicians don't recognize eggshells pa, wala talagang pag-asa yung patient. So this has been a very relentless campaign to ensure that we send out the message to the most number of people, whether we're talking about inflammatory back pain or this new paradigm of thinking about eggshell spa, because this is the only way that we will be able to capture and care for our patients earlier.
Thank you very much. And I think that would conclude our session for today. Dr. Reyes, thank you for answering those questions. As expressed by our audience, they learned a lot from you today. And thank you to our audience for the active participation, asking relevant questions, showing much interest about rheumatology. I hope that for you who are undergoing training, we can see you in the division as our trainees. We would like to thank the IMS, Information Management Service Network team of the UP Manila and our sponsor, Pfizer. Thank you all for joining us. We hope to see you all again in November for another informative and timely lecture. Have a great afternoon. Over to IMS. Thank you.